Mike Gibson, Hyo-Soo Kim, coming to you live from ACC 2025, and we're talking about different durations of dual antiplatelet therapy in people with low or higher bleeding risks. Talk to us a little bit about what you did and what you found, Dr. Kim.
Yeah, uh, I will represent host BR trial in the upcoming ACC LBCT session. BR means bleeding risk. Background of this host BR RCT is there's no previous study that evaluates specific duration of DAPT, dual antiplatelet therapy, stratified according to bleeding risk. The general recommendation is about 3 to 12 months DAPT for low bleeding risk population and shorter 1 to 3 months DAPT for high bleeding risk population. The general consensus is shorter DAPT may be slightly more beneficial than long DAPT because it is associated with less bleeding event, but we don't have evidence based on BR. Which duration would be optimal and where the thrombosis bleeding risk will cross. That's the reason why we started this study. This is a stratified randomized clinical trial enrolling the dedicated HBR population as well as low BR population based on ARC HBR definition, which was proposed several years ago by global leaders, including me. As a study design of this host BR RCT, we first stratified about 4,900 patients into two stratum, high BL and low BL. About one third, about 1,600 patients are included in high BL. That is the usual situation in every cath lab. We randomized them into DAPT 1 month versus 3 months, followed by single agent up to 1 year. And for low BR stratum, that usually constitute about 2/3 of population in every cath lab. And in this study, about 3,300 patients were randomized into DAPT 3 versus 12 months. Then we checked 1 year outcome.
And what did you find?
Yeah, primary endpoint is 3 component. The first one is NACE, net adverse clinical event, that is defined as composite of all death, all infarction, stroke, major bleeding defined by BARC type 3 and 5. The second component of co-primary endpoint is MACC, major adverse cardiac and cerebrovascular events. That is composite of cardiac death, infarction, stent thrombosis, and ischemic stroke. That is a thrombotic endpoint. The third component of co-primary endpoint is major or minor bleeding, defined as BARC type 2, 3, and 5 bleeding. So we analyzed these 3 components of co-primary endpoint as a hierarchical order. This first, we checked non-inferiority of shorter DAPT in high BR stratum. The first component is 1 year NACE in the high BR stratum was about 18.4% in 1 month group versus 14%, 0% after 3 month DAPT. Non-inferiority was not met. The risk difference is about over 4%. As a short DAPT was inferior in terms of NACE to 3 month DAPT. Thus, we did not continue non-inferiority test for the second component, such as 1 year MACC in this high BR stratum. That is our original statistical analysis plan. Thus, we checked the event rate, MACC, In shorter 1 month depth, that was about 9.8%, whereas 3 month depth, 5.8%. The risk difference is about 4%.
Mm, mm-hmm, mm-hmm.
Non-inferiority was not met. The
Wow.
shorter depth was actually inferior
Mm-hmm,
to three
mm-hmm.
month depth in terms of MACE thrombotic endpoint.
Wow.
And third component of primary endpoint is BARC type 235 bleeding, any actionable bleeding.
Mm-hmm, mm-hmm,
That happened about 13.8% in 1 month depth versus 15.8% in 3 month depth. This difference did not reach statistical significance.
hmm. Wow.
To
Okay.
summarize the results of high bleeding risk stratum, the first component, NACE, was inferior in
Mm-hmm,
1 month.
mm-hmm, mm-hmm,
MACE was also inferior with 1 month than three
mm-hmm,
months. Bleeding difference is not significant.
mm-hmm, mm-hmm.
Then how is the results in low bleeding risk stratum? The first component is 1 year NACE. That was about 2.9% after 3 month depth versus 4.4% after 12 month depth. Non-inferiority was met.
Wow. Okay.
Second component is 1 year MACCE, thrombotic
Mm-hmm,
endpoint in low BR stratum. That was 2.2% after 3 month depth, 2.3% after 12 month depth, non-inferior, exactly
wow.
comparable. The
Mm-hmm,
final component is actionable anti-bleeding, BOG235 bleeding in low BR stratum, happened in 7.4% after 3 month depth, but 11.7% after 12 month depth, significantly different. The
yes.
difference is about 4.3%. To summarize the 1, 2, 3 component of co-primary endpoints in low BR stratum, 1 year NACE, non-inferior, comparable. 1 year MACE was also comparable between 3 versus 12 months, but bleeding was significantly less with 3
Mm-hmm,
months than 12 month depth. But to summarize our study, in HBL population, 1 month depth did not meet non-inferiority to 3 month depth for NACE. Thus, we did not further analyze non-inferior test. Actual difference was greater. Thus, 1 month depth was actually inferior to 3 month depth for NACE and MACE at 1 year, while there is no significant difference in any actionable bleeding. In low BR stratum, 3 month depth reduced any actionable bleeding without increasing NACE or MACE as compared with 12 month depth. Overall, 3 months would be the optimal default duration of depth after PCI in general to meet the balance of thrombosis and bleeding, regardless of the patient's own bleeding risk profile.
Well, very good. I'm really pleased that you did this because we need more information about those low bleeding risk patients. You filled in an important gap there in our knowledge. Looks like it's safer to give 3 months than 12 months in those people without a penalty in terms of ischemic events. Really no benefit to going to 1 month, though, in the high bleeding risk patients. So 3 months was the winner in both. Dr. Kim, thank you so much for joining us today. Thanks for sharing.
Thank you very much for having me.